Interstitial lung disease ILD is an respiratory disorder. Look at this picture shows that lungs, respiratory units, alveoli wall, then high resolution computed tomography HRCT findings. Look at this, identifies lung fibrosis patterns. Chest X-ray shows reticular or nodular opacities. Look at this in right side lungs. A detail going on. Introduction. Interstitial lung disease ILD refers to a group of lung disorders that cause progressive scarring, fibrosis of lung tissue, affecting breathing and oxygen exchange. ILD can be caused by environmental exposure, autoimmune conditions, infections, or be idiopathic in nature. Etymology. The term interstitial lung disease originates from the Latin word interstitum, meaning space between, referring to the lung tissue affected by these diseases. ILD encompasses a group of disorders that cause inflammation and scarring of the interstitial space, impairing lung function. A definition. ILD encompasses a broad categories of lung diseases that cause inflammation and fibrosis of the lung interstitum, the space around alveoli, blood vessels, and airways, leading to reduced lung function and impaired gas exchange. Types 1. Idiopathic pulmonary fibrosis IPF, a chronic and progressive form of ILD with unknown cause. 2. Hypersensitivity pneumonitis HV, inflammatory lung disease caused by exposure to organic particles like mold, dust, or bad droppings. 3. Sarcoidosis, granulomatous disease affecting multiple organs, including the lungs, 4. Connective tissue disease associated ILD. ILD linked to autoimmune disease such as rheumatoid arthritis or scleroderma. 5. Pneumoconiosis, occupational lung disease caused by inhalation of harmful substances like silica, asbestos, or coal dust. 6. Drug induced ILD, lung toxicity caused by medications such as chemotherapy, drugs, antibiotics, or anti inflammatory agents. Causes: 1. Environmental and occupational exposure. Asbestos, silica, coal dust, mold, bird droppings. 2. Autoimmune diseases. Rheumatoid arthritis, lupus, and scleroderma. 3. Infections, viral, bacterial, fungal infections. 4. Genetic predisposition. 5. Medications and radiation therapy. 6. Idiopathic cause, unknown origin. Risk factors: 1. Smoking. 2. Long term exposure to pollutants and irritants. 3. Family history of ILD. 4. Chronic infections. 5. Certain medications, chemotherapy, amiodarone, methotrexate. 6. Radiation therapy to the chest. Complications: 1. Pulmonary hypertension. 2. Respiratory failure. 3. Lung cancer. 4. Right heart failure. 5. Reduced quality of life due to progressive breathlessness. Pathophysiology: ILD leads to repeated injury to alveolar epithelium, triggering an abnormal healing response. Instead of normal repair, fibroblasts accumulate, causing excessive deposition of collagen and extracellular matrix, leading to fibrosis and thickening of alveolar walls. This fibrosis reduces lung elasticity, impairs gas exchange, and leads to hypoxia. Pathophysiology of interstitial lung disease: step by step process. 1. Initial injury to the lung. Parenchyma. 2. inflammatory response activation. 3. Increased vascular permeability and edema formation. 4. Fibroblast activation and extracellular matrix deposition. 5. Alveolar architecture disruption. 6. Loss of lung compliance and progressive fibrosis. The lung tissue becomes stiff due to excessive fibrosis, reducing lung compliance and making breathing increasingly difficult. This results in restrictive lung disease with reduced total lung capacity TLC and forced vital capacity FVC. 7. End stage fibrosis and respiratory failure. As fibrosis progresses, lung function continues to decline, leading to severe hypoxemia, pulmonary hypertension, and ultimately respiratory failure. In advanced cases, lung transplantation may be the only treatment option. This progressive process varies in severity and rate depending on the specific type of ILD and the underlying cause. Signs and symptoms. 1. Progressive dyspnea, shortness of breath. 2. Chronic dry cough. 3. Fatigue and weakness. 4. Chest discomfort. 5. Clubbing of fingers in some cases. 6. Unintentional weight loss. 7. Fine crackles on lung acirculation. Diagnosis. 1. Clinical assessment, history taking. 2. Pulmonary function test to measure lung capacity and airflow. 3. Imaging studies, high resolution computer tomography, HRCT, identifying lung fibrosis patterns. Chest X-ray shows reticular or modular opacities. 4. Bronchoscopy with bronchoalveolar lavage to collect lung samples. 5. Lung biopsy for histopathological confirmation. 6. Serological test to identify autoimmune related to ILD. Nursing diagnosis. 1. Impaired gas exchange related to lung fibrosis. 2. Ineffective airway clearance due to persistent cough and mucus production. 3. Activity intolerance related to dyspnea and fatigue. 4. Anxiety due to chronic illness and respiratory distress. 5. Risk for infection due to compromised lung function. Medical management. 1. Oxygen therapy to relieve hypoxia. 2. Medications. Corticosteroids to reduce inflammations. Antifibrotic agents to slow fibrosis progression. Immunosuppressants for autoimmune related ILD. 3. Pulmonary rehabilitation includes breathing, exercises, and physical therapy. 4. Lung transplantation considered in advanced stage ILD. Nursing management. 1. Monitor respiratory status, oxygen levels, respiratory rate, lung sounds. 2. Educate patients on smoking cessations and avoiding environmental triggers. 3. Encourage pulmonary exercises to improve lung function. 4. Provide psychological support to manage stress and anxiety. 5. Administer prescribed medications and monitor side effects. Treatment. 1. Pharmacotherapy. Corticosteroids, antifibrotic agents, and immunosuppressants. 2. Oxygen therapy to manage hypoxia. 3. Pulmonary rehabilitation to improve functional capacity. 4. Lung transplantation in severe end stage ILD cases. Psychosocial medicine. 1. Patient education and counseling helps in understanding disease, progression, and management. 2. Support groups offer emotional and peer support. 3. Cognitive behavioral therapy CBT manage anxiety and depression. 4. Family involvement and caregiver support encourage adherence to treatment. 5. Mindfulness and relaxation techniques reduces stress and enhances coping mechanisms. Prevention. 1. Avoid smoking and exposure to lung irritants. 2. Use protective gear in occupational setting. 3. Routine health checkups for early detection. 4. Vaccination against influenza and pneumonia. 5. Early treatment of autoimmune and respiratory infections. In conclusion, interstitial lung disease is a complex and progressive lung disorder with diverse causes and types. Early diagnosis, appropriate medical management, and lifestyle modifications are key to slowing its progression. A multidisciplinary approach involving pulmonologists, nurses, rehabilitation therapists, and mental health professionals can significantly improve the patient's quality of life. Thank you. Have a nice day.